the UN agencies representatives, directors of different cooperative partners, both local and international, and the pharmaceutical companies that are represented here. ZAGO members, supporters, media, may I simply say, ladies and gentlemen, most of the time we attend a function, some people really struggle to really say, why are we here? Even when you are leaving home, your better half asks, what are you going to do? So we are simply here to highlight a big problem on our hands, the problem of maternal and newborn mortality or death. We are also sharing with you what strategies we've put in place as Zambia Association of Gynecologists and Ministry of Health, and focus areas we'd love you partners to support. You are aware that in 2019, maternal and perinatal mortality were declared as a public health emergency, which was a call for action to mobilize resources and end preventable maternal and perinatal mortality. You agree with me that in the last 20 years we have made quite some strides. We have managed to reduce maternal mortality by almost 60%. Ladies and gentlemen, we can be upstanding for the guest of honor, PS Dr. Lakson Kasonka. We can be seated. Okay. You're welcome, sir. I was just whispering with the Master of Ceremonies in Gala that our beloved Permanent Secretary, Dr. Lakson Kasonka, is one of us and would not have any difficulties fitting into what is being discussed. So he is not late but delayed. You are welcome, sir. Thank you. So I was just giving a lowdown on the problem of maternal and newborn mortality. Over the last 20 years as a country, we have made strides. We have reduced maternal deaths by close to 60%. In 2002, our maternal mortality was 729 per 100,000, 729. In 2018, almost 20 years down the line, we've managed to bring it down to 278 per 100,000, but still unacceptably high. Most of the causes of the maternal and perinatal deaths are largely preventable. Top on the list is bleeding, especially bleeding after childbirth, followed by hypertensive disorders, followed by infections and unsafe abortions. For the perinatal mortality, breathing difficulties or asphyxia after delivery, prematurity, and infections. Guest of honor, it is in this context that ZAGO is hosting this gala to exchange views, ideas, and experiences on how best, as a country, we can drastically reduce the maternal deaths in line with the 8th National Development Plan, Sustainable Development Goals number 3, and the Vision 2030. As Zambia Association of Gynecologists, we have been on the front line. Our members are spread all over the country. I'm happy to announce that guest of honor that almost all the provinces now will have a minimum of 2 or so gynecologists. Our resolve is to save lives of women and newborns and ensure that no woman dies while giving birth and subsequently bring down maternal deaths. There are key strategies that we have been working on together with the Ministry of Health. Top of the list has been the emergency obstetric neonatal care, strengthening referral guidelines and clinical protocols, reviewing maternal deaths, which are now being done weekly, so that remedial measures are found after identifying the gaps. We've also invested as an association together with the Ministry of Health in focused or evidence-based antenatal care, where programs should be picked early and the prompt referral to the next level of care is instituted. This evening, we shall take you through highlighting the big problems that we are facing as a country in maternal and perinatal mortality. We'll give you the statistics. We shall show you what are the major causes of our maternal and perinatal mortality, and also where these deaths take place and the age group. Strategies that were put in place will be highlighted. Then we'll draw you to our focus areas. What do we want you who have gathered here to do for us? I think most times we have gone to look for money. I remember entering offices even as a young doctor then. You are looking for support. The person seated behind a big chair behind asks a question, what really do you want me to do for you? So we have really simplified the focus areas into 4, and these will be highlighted during the slide and video presentation. I thank you so much for coming this evening, sparing your precious time to come and be part of a group that will be remembered to have walked the talk to save maternal and newborn lives. Ladies and gentlemen, we ask you to be very interactive this evening. It's more of an interactive forum, exchange ideas. No single contribution will be just thrown down. You never know what will be the missing link to addressing our problems. Thank you for your attention, and now we turn to the presentations. I think before the presentations, it's my singular honor, guest of honor, just to give your opening remarks or speech. Peers.
Thank you very much, Dr. Macha. First of all, it's wonderful to see all of you, your full faces without the masks. It's been a long time, such that we started to forget some of our colleagues and friends as to what they look like. So since yesterday, we are no longer going to wear the masks around with us. I want to start by recognizing all of you that are here. Particularly, I take note of the presence of the Zambia Medical Association President, Dr. Moyo. I recognize and thank Dr. Macha, the President of the Zambia Association of Obstetrics and Gynecology, who has just accorded me an opportunity to come and stand in front of you and share a few words. I recognize Mr. Daniel Sinclair, the Director for the Medical Corps at the USAID. I also recognize many of you representatives of various important organizations, the UN family, and all of you that I'm not able to pick out. I also recognize the press. Ladies and gentlemen, I'm truly excited to be part of this very wonderful gala evening. The Minister of Health, too, would have been delighted to be with us this evening. It is particularly joyful for me because this gathering is the family that I belong to. I have to mention that for the last 10 months in my new assignment, I've had to perform many different tasks. This gala brings us together to share thoughts on maternal and newborn health, a subject that is so critical to the development of humanity. I'm conscious that as we articulate this subject, we will share evidence-based views and experiences on how best our country can completely avoid preventable maternal deaths by the year 2030. This is important not only to saving lives of our women and newborns, but also a fundamental pillar for national development. There are various causes, like we've heard from the preliminary statement by the President of ZAGO, that there are various causes of maternal death in our country. The most reasons being, like we've heard, excessive bleeding before, during, and after childbirth. Other causes, of course, include infections, hypertensive disorders of pregnancy, and complications due to unsafe abortions, among others. On the other hand, birth asphyxia, prematurity, infectious conditions claim the young lives of our neonates. Any maternal and perinatal death is unacceptable, and a gathering like this should always focus on finding a stop to that injustice. The government, the Ministry of Health, is cognizant of the commitment that ZAGO shares to ending this injustice. The New Dawn government is further aware of the contributions from other partners towards the various interventions against maternal and neonatal mortality. It is gratifying to note from the Demographic and Health Survey of 2018 that maternal mortality ratio declined, like we've heard again, to 270 per 100,000 from 398 per 100,000 in 2013-2014. But this rate still remains unacceptably high, and we can do more to further reduce preventable causes of maternal deaths. We also agree that 90% of maternal deaths happen in our health facilities. This means that the key interventions really are within our control. So, where is the problem? The neonatal mortality rate, on the other hand, declined from 27 per thousand live births in 2013-2014 to 24,000 live births in 2018. Again, a marginal improvement where significant progress would have been preferred. The Ministry of Health, in its National Health Strategic Plan 2022-2026, will reinforce key interventions focused on the following. Firstly, a strong focus on emergency obstetric and neonatal care. Secondly, we will ensure to strengthen maternal and neonatal referral system. Further, we will scale up maternal and perinatal death surveillance and response. Subsequently, the WHO 2016 antenatal care recommendations are extremely cardinal, and our ministry has adopted those recommendations for rollout in the strategic plan 2022-2026. We also aim in that plan to eliminate vertical transmission of HIV. In the same plan, we shall remodel family planning with a stronger emphasis on long-acting reversible methods. And finally, but not the least, we shall also expand access to cervical cancer screening and provide skilled attendance at birth, particularly in remote areas. Further, regarding emergency maternal, obstetric and neonatal care, the Ministry of Health places emphasis on site-targeted mentorship in life-saving skills. This entails setting up triage system and high-dependent care units at all first, second, and third-level hospitals. Labor drills are an important skill reinforcement procedure. These will be performed regularly, together with close monitoring of postnatal patients in the first 24 hours of birth. In all this, we expect ZAGO to lead the process of setting up obstetric intensive care units in other teaching hospitals besides the university teaching hospitals and the woman and newborn hospital. This is key in successfully managing critical cases to abate mortality. This ministry certainly appreciates the leadership role by ZAGO in the recently established National Maternal Perinatal Death Surveillance and Response Team. As you know, the function of this team, among others, is to critically analyze maternal and perinatal deaths and to offer solutions towards maternal deaths control. I also wish to pay tribute to ZAGO for the recently launched referral guidelines that will lead to improved referral system with subsequent improvements in maternal and newborn survival. It is worth noting that the government is concerned about the current challenges that are being experienced in providing quality obstetric and neonatal care owing to dilapidated infrastructure, shortage of medicines and other medical commodities, surgical instruments and essential diagnostic equipment, and coupled with patient transport for an efficient referral system. I can only assure you, ladies and gentlemen, that these issues are receiving deserved attention and should be addressed soon. In appreciating the role of ZAGO in the agenda to improve maternal and neonatal health, I implore other groups and partners in healthcare, including the USAID, the CDC, the World Health Organization, and the pharmaceutical companies to collaborate and network with ZAGO and the Ministry of Health through strong partnerships as a key initiative towards the zero maternal mortality by the year 2030. The Ministry of Health is determined to improve and strengthen access to cost-effective, quality, and essential maternal and neonatal health care services as close to the family as possible. Through these partnerships, we will also strengthen education and clinical training for our nurses, for our midwives, and for our doctors, which ultimately will lead to a very competent and skilled workforce. At this moment, it is now my distinct honor and delight to open the ZAGO 2022 banquet. Best wishes. Thank you for listening.
So the overview of maternal and mortality, like Sinkala said, these slides are really short, well packaged to send the message and not keep you long. I know you are very busy people. So that's the situation. I think I've already mentioned those statistics. Next. That's the current situation, not in any way meant to alarm, but a reality of 10 to 15 maternal deaths weekly, annually about 700 to 750. Neonates, those are the newborns, 50 to 70 weekly. So you can see why we are here and worried. Next, the top four. This is based on the 2020-2018 statistics. Hemorrhage still continues to haunt us, 40%. Hypertension, 15, and safe abortion, 9, infections, 8. The indirect causes are those that include pre-existing diseases like sugar, HIV, malaria, and also cardiac disease. This situation is compounded by other health system challenges, such as the shortage of health workers. We are PS grateful to your government that we have had a recruitment of new health workers. There is a shortage of drugs. I know you are trying to address this, lack of equipment and supplies, dilapidated infrastructure, and poor road network. This is, again, the reality where we are coming from. The curve is dropping. I think that's a good sign, but again, still unacceptably high. So this is where I say, when we are long gone, I think the country will remember us that this generation tried their part to lower down these deaths. Next, we got a snapshot of 2021 where we recorded about 690 maternal deaths. So you can see in gross figures, Lusaka and the twin province of Copperbelt usually on the higher side. Now, I always challenge my colleagues in Lusaka and Copperbelt that, look, when I get calls from friends outside the country, in other African, they ask, but are these two provinces hard to reach while you are recording these high figures? Of course, one will argue, no, there is high density of population, but then they have overcome by the fact that most of the experts reside in these two provinces, good communication, transport system, readily available blood products. So you really wonder, where are we getting it wrong? Next. So 2021, those are the common causes. You can see the hemorrhage is there at 39, so hovering close to 40. Infections 11 and hypertension 10%. Abortive outcomes, I can say that thanks to organizations like ZAGO, with a political will from Ministry of Health, abortions are really coming down, 4%, 2021. Next, Now you look at the age group of people who we are losing, most of which are very, productive people, very young. They are in the age group 14 to 35. You can see the 24 to 33 age group, 292. These are people at the peak of their lives. They are climbing the social, in terms of economic social life ladder. And these are the ones we are burying. So this is just a snapshot of 2021. Next. In conclusion, these deaths are largely preventable, and targeted interventions can reduce them to less than 70 by 2030. And the years are really roaring. The same way we were saying 2015 MDGs, we were targeting less than 162. The year came, we missed the target. I only hope that if we put our heads together, we are able to celebrate at the end of the age. I've seen there, we have Professor Kasonka, the PS, Professor Bwalika. They have been our teachers, leaders in this fight, and I would love them to retire with this figure reached. So that's an overview, just to take you through where we are.
Is anyone having questions or comments on the presentation? Yeah, I've seen the hand from the President, from His Excellency. You can proceed.
Thank you very much, Director of Ceremonies, and thank you very much, President Macha, for that elaborate presentation. Yeah, I think for me what stands out under maternal mortality is that we have a known cause, which is hemorrhage, peripartum, postpartum, but we know that it's hemorrhage. But also another thing that stands out is that Lusaka and Copperbelt, where access to services and resources, including just the general economic status of the clients, is expected to be better. We seem to be doing very badly. From your analysis and what you have observed, what is the main driver, especially in these two places which are taking up maybe, I'm just using a figure in my head, maybe 40% or 50% of the country's resources in health, including human resource? Thank you.
Thank you so much, Dr. Moyo. Very important question, and I would even throw it to my fellow obstetricians. We have some working from the first level hospitals. From our reviews, weekly reviews, we have noticed that there are a number of factors, but key has been the skill and knowledge gap, especially from referral centers, and also failure to follow referral guidelines. Patients who are supposed to be referred early, presenting late. There could be, of course, community factors, but most of these deaths occur in our facilities, I think 90%, and we've noticed that there is some skill and knowledge gap at the primary levels, where the problems are not identified early. By the time they reach the tertiary hospitals, there is a lot of complications that are set in. So we need to go back to the referral centers, do skill and knowledge transfer through on-site mentorship, take them through the referral guidelines, and also to enhance antenatal clinics so that their problems are picked early. For example, high-raised BPs, if they are missed, one is given a long review date, they end up coming with the complications. So it's an issue of skill knowledge gap, failure to adhere to referral and clinical protocols. somebody can add on that.
Thank you very much. My name is Amit Kamanga. I'm Vice President for ZAGO. I think I'm not going to approach it in terms of why is it like that. I think a lot of the things that Dr. Macha has indicated are things that are recurrent that we know. I was just whispering to Dr. Moyo, this is something we need to understand further. I think what Dr. Moyo has asked to me sounds like a very good research question that we need to do. And I think if we have the support to do so, because we need to really go down and understand how we can still have such a high mortality rate where services are closer as compared to places where services, I know it's the issues of ratios and in terms of population density, but I think if there are places where we should be rapidly bringing down, especially cases of hemorrhage, it should be Lusaka and Copperbelt. I think in these places we should ideally be bringing these days down. So we really need to go and understand. I think we need to answer this question scientifically. Why Copperbelt and Lusaka still has high maternal deaths when facilities are probably much closer, when the human resource, the experts, the density of the experts are also present in these provinces. Thank you.
Thank you very much. My name is Dr. Christopher Ngandwe, a member of ZAGO and past ZAGO president. I just want to add on to the perspective of Lusaka having high maternal deaths. I think it's also the issue of population. We really need to look at the issue of population, and we know that Lusaka has the highest population in the country. So if we are talking about absolute numbers of maternal deaths, it's obvious Lusaka will have higher numbers. But when we look at the ratio of maternal deaths per 100,000 live deaths, I don't think the picture will still be the same. But that said, I think they still need to actually address the issue of maternal deaths. Copperbelt, Lusaka, they have the highest numbers. And not only that, but also we have a lot of undocumented people living in these two cities, in these two provinces, in terms of, foreigners who've trekked in for businesses and so on. So the numbers are high when we talk about absolute numbers, but when we talk about the ratio, I think the picture will be different. I submit. Thank you.
Thank you very much. Ideally, I'm supposed to be the last guy to speak, or I should not even speak at all, but just listen and take responsibility. But I'm going to stimulate a comment from the ZAGO. You know, as a fistula surgeon myself, and in the epidemiology of fistula, I will talk about 3 delays towards mobility. And these are delay in, first of all, at the domestic level, the family making a decision that this patient ought to go to a hospital. Secondly, is the transport to get that patient to the health center. And often these 2 delays happen in the rural areas. The 3rd delay is where the patient has arrived at the hospital and there's delayed intervention. This delay, the third one, would be applicable to the two sites in under discussion, that is Lusaka and the Copper Belt. I want to hear thoughts from ZAGO. Why does a third delay happen at the facility when the patient has arrived, but end up with a morbidity, severe morbidity, or mortality, unfortunately? Can we speak to the third delay at the hospital?
Thank you so much, PS. That's another very cardinal contribution. I equally acknowledge what Dr. Kamanga, who said this is really a research question. Even Dr. Ngandwe's contribution on the population dynamics and also the need to critically compare the numbers. Yes, you are very right. There is a third delay, which even us who are in tertiary hospitals, we used to experience, especially when we had little operating space, where you find you have to triage patients who are already triaged for surgery because of lack of space. There are also other factors, maybe anesthetists not being adequate, theater nurses. So those are also contribute to the third delay, where the patient arrives at the hospital with an already decision made to operate, but you can't do it immediately because there is no space, there is no anesthetist or theater nurse. But these are usually addressed either at institutional level or with the intervention of the ministry. I recall how we opened an additional emergency theater in UTH in labor ward to create more space. But it is indeed, I totally agree, one of the factors, and I really support also what Kamanga said in operational research. I don't know what your comment is, Professor Warika.
Thank you for putting me on the spot, Dr. Macha, but I'm happy to report, I think PS saw it on his office, that WHO is taking a keen interest in the definition of skilled birth attendant. In other words, what would we say is the useful and feasible measurement, because we are talking of statistics here. So we may say that we have a lot of staff in Lusaka, but what's the definition of skilled birth attendant? That woman who died, who was not referred, who was not operated on time, what is this definition? So I would say that there is a protocol that is being developed, and hoping that we can come up with a consensus on what would be a useful and feasible measurement, and this may be an eye-opener as to why we may have so many numbers of trained people and yet we are having this third delay. People are still dying. Thank you.
Thank you very much, Dr. Musonda Makasa, also part of the ZAGO executive, but of course gynecologist and obstetrician. I'm glad the discussion has gone in this direction and the dimension that has been brought up in terms of the delays. Okay, much as we can say that majority of the mortalities are in the institutions, and which is a manifestation that there's a problem with the delay. But one of the attributing factors, I think, is that much as we can say that the density or the concentration of the health workers are in these two provinces, for example, Lusaka and the Copper Belt, but the skill aspect is another. I won't go deep into that. I think the Professor Volika has already alluded to it. And so the challenge we're having right now is the attrition of that skilled personnel. That's number one. Number two is the ratio of that skilled personnel to the health seekers. Okay, so despite that, then we also go back now to the first delays. Poor health seeking behavior or communities, but maybe that might be because of attitudinal things, might be geographical issues, okay, but fine, the discussion is on Copper Belt and Lusaka, but that aspect can apply to other areas. But then there are also other cultural issues, and why I say this is that we still see a lot of, a good proportion of women with high risk factors that will report late. So much so that even by the time that interventions are setting, it becomes a little too late. Nobody has talked about blood products. It's another challenge. The past few weeks we've been having that challenge. This week is a slight improvement. Okay, the rest is for another discussion. So all in all, what I'm trying to say is that in conclusion, let me just put it that way. The staff attrition, the ratio of the skilled labor, the attrition of that skilled labor, then the ratio of the skilled labor, skilled personnel to the health seekers, and then also the health, health-seeking behavior of the people. And why I say this, that is manifested through the perinatal mortality. Right now, okay, we can say MDs or maternal deaths because of hemorrhage and what, or things like that. But there's another manifestation there. When we looked at the figures on the perinatal mortalities, we're talking about women, pregnant women, per week across the country losing in the range of 50 to 70, might even slightly be more. Yeah, but again, one of the key performance indicators in our care is perinatal mortality. It means there's something that is still amiss. Where is it? Where is the gap? I think I'll end there. Thank you.
Thank you. I'm Astrida Maseka. Yeah, I'll just, in answering to the question, I think we still have the delay at the level of the community, even within Lusaka. You find that there's that delay, first of all, but then when this woman comes to the health facility, in my analysis, well, I stand to be corrected, but in my analysis, what I do think as well is that the coming of the general hospitals now is more of a double-edged sword. Well, I was just thinking through, if we could compare, say, how many deaths we were having before, when there were clinics, the time the first level hospitals were clinics, compared to now that they're first level hospitals. Because what I see is there's decongestion of UTH and say Levy Hospital. Yet again, decision making at the level of these general hospitals takes a while, because also we have a lot of interns there, then the consultant. By the time these interns will say escalate the issue to the consultant, they do take some time sometimes, and that will result in that delay. And besides that delay at that level, there's also the delay of transportation. I think in the district, there's still an issue of where this ambulance has to pick a patient from one facility to the other facility, and then before they come to, say, Women and Newborn Hospital or Levy. So by the time you're having this lady, actually, you get a woman who's critical compared to those days when it was a clinic, when they were operating as clinics, because then they would make those decisions like urgently patient comes. But what I see now is this delay at the level of decision making at these hospitals, but also transportation, where when they're coming, they're really critical. I think we get women that are critical. When they come in our triage, they are critical. So my submission. Thank you.
Thank you very much. I'm not going to respond to any of the questions, but I will start with the igniting thing that Professor Laxon has mentioned, about the delay factors. I'm happy with the data that's presented by the president that delay one is maybe a problem, but it is not rampant in Zambia. I didn't see uterine rupture, all those things that happened due to that. Probably Zambia has solved it maybe many years back. But this hemorrhage, it is still there, especially if you see PPH, which is very common in one of the major killers in Zambia. Delay one is not yet addressed enough because it kills in 2 hours or so. So maybe when the woman with PPH comes to the facility, already she is on the verge of death. She is either a near miss or she is already missed. So still there is a quality of care issue that we have to address. But whatever we do, quality of care is not only in the facility, we have to go up to the level of the community along all continuum of care. Having said this, the other thing is that I saw in your presentation, there are challenges that are presented, but I would have loved to hear as well, what are the things done in Zambia to address these figures? I think we have these figures. It's not only for statistics purpose, it is for actions that we generate them. So, like MPDSR is implemented in Zambia, is going very well, although it is not strong. I know there are so many good initiatives in Zambia, and Zambia has been one of those countries engaged in the WHO African Regional Action Plan preparation to eliminate preventable PPH and preeclampsia related diseases. So there are so many good things that have enabled Zambia to reduce maternal mortality by 60%. We have to document these lessons. We have to strengthen them. Maybe if we do more on those things, it may take us with maybe up to the zero elimination, that is going toward the zero. So let's work on our strengths and then let's use the evidence for our action. Yeah, thank you very much. I didn't introduce myself. I am from the World Health Organization. My background is in obstetrics and gynecology, although now I'm doing something else. I've been a member of the Ethiopian Society of Gynecology and Obstetrics. And thank you, President. You have promised me that I will be an associate member of your association. So, yeah, thank you.
My name is Moffat, a young person working for Tikambe Natulande, where we talk about sexual and reproductive health for the young people. So just to build up on her point, so you find situations where, like when I'm on the ground talking to different young people concerning sexual reproductive health, there are issues that come up to say there are fees that are attached when they visit a health facility to undergo abortion. You find situations where a young person doesn't have money to undergo an abortion, and doctors outside will be, no, you have to pay this much. I can't leave what I'm doing to attend to you, so you have to pay a certain fee so that you can, undergo this service, which discourages young people, and as a result, they undergo unsafe abortion. And also issues to do with parents. It was shocking to me when I do have meetings with parents like every month, where we talk about different sexual reproductive health, how they can talk to their children about issues to do with sexual reproductive health. So the funny part is, I think some of them came to know about how legal abortion is, and when abortion was legalized, some of them didn't know about how legal abortion is. So I feel there's no information, there's no knowledge when it comes to parents on how legal is legal abortion. They have no idea. So this is where you find their child gets forced pregnant. What's going to happen is we're going to go back to cultural norms where we grew up to say, no, it's a taboo, it's what. So parents have no information when it comes to that. They'll rather maybe point fingers at their child, no, you are a disappointment, and as a result, a child would go and undergo unsafe abortion. So if we can put those measures in place and explain to the community the measures that they have to put in place for them to undergo an abortion, I feel that would be nice, because we have a lot of young people who are dying due to unsafe abortion, and when they go to the clinic, it's actually too late for them to undergo an unsafe abortion. So I feel if we can put those, if we can put that in place, I feel we won't have as much, abortions amongst the young people. Thank you.
Let us have a microphone given to the President.
So thank you so much. Very quality debate and exchange of views. I think what is coming out is it is indeed a problem, and we need to have an in-depth analysis of the deaths, especially in Lusaka and Copperbelt, where there is seemingly expertise, good communication, and also the addressing of the third delay, mostly to interventions at the hospital level. But also what is coming out is the need also to consider the community level also, involvement of the community. That calls for strengthening the SMAGs, safe motherhood groups, so that they are the conveyors of accurate information, making the women to come to the hospital early. Yeah, we can't ignore those. Yeah. But something as we move in the evening, we continue brainstorming. I think there is no problem without a solution. So this has been the strategy I've been using with Ministry of Health, provision of EMOC, setting up high dependent care units for the critically ill, obstetric, and the triage appropriate for the level of care. Adherence to clinical protocols and referral guidelines, setting up operating theaters for Caesars in all high delivery facilities, and improving availability of obstetricians and in all provinces. And thanks to a robust training program, I think Professor Walika have been instrumental in increasing the number of specialists in OBS and GYN. Focus one has been the site Zambia, where I would want to transfer skill in the rural areas, even peri-urban areas where we feel there is a gap in the site skill. If we are able to transfer safe surgery skills, we expect good maternal and newborn survival. This is a 3-year project. We have worked on a detailed budget which we can talk to our partners and see how they can come on board and be part of history, which will vindict you that you contributed to the greater survival of our mothers. I think this was a mentorship, surgical skill transfer. We were in Eastern Province, Minga Mission Hospital, very busy, being run by 2 general medical officers. So that day we took it upon ourselves to transfer skill to them. It was quite busy. I think I knocked off quite late. But with the visit, you can see that the young doctors in the district really appreciated. Next, we were pick of things. This was in Kalindawalo Specialized Hospital. Again, 2 general medical officers working, serving a very big population. We spent time with them, transferring the knowledge, the skill. I traveled with a theater nurse and the midwife, who were very instrumental also in transferring the skill. There, this was still Kalindawalo with the midwife waiting for the baby. Focus area 2 has to do with the on-site mentorship, labor ward drills. PPH is the leading cause. Just having regular drills prepares the health worker to respond in time. Just like my colleague from WHO stated, time is critical from decision making to intervention. If you delay, you end up losing that woman, especially for bleeding. So there we were. This was Professor Walika. At that time we are rolling out tranexamic acid. This was a mentorship visit in Nimba District Hospital. So you can see the advantage of on-site as opposed to classroom-based. Here they see you perform. You have sometimes a live patient and they see you deliver, suturing, managing the PPH. The transfer of the skill is immediate and it sticks in the minds of the learners. The MPDSR trainings, WHO has been instrumental. We feel one area which needs strengthening so that we correctly assign the cause of death, the underlying, what triggered. I remember attending one MPDSR where people are just saying this patient couldn't have died because there was no blood. But the real problem, it was a ruptured uterus. When I asked them, give me the pathograph, it had gone way beyond the action line. So then someone will say the cause was no blood. No, it was an obstructed labor which you didn't monitor. So if you don't correctly assign the underlying cause, your interventions will be working upside down. So this training is very important. It's a 2-year program. We need support for this so that we go throughout the country so that people are able to correctly assign the underlying cause for targeted intervention. Antenatal, I've already emphasized why this one is very critical, the mentorship. Programs are missed during antenatal. We have had cards where the BP is really very high, and this woman is given 1 month review. The next, she comes comatose with bleeding from the brain, and UTH will not do much. We lose these women. So the problem is failure to pick out the problem during antenatal. Also failure to refer to the next level of care. You find someone has 3 previous surgeries to the abdomen, to the uterus. They are being told, come next week. The next referral will be when she's in labor. Comes as an emergency. So these are the women that we are losing. So if we can hold the antenatal, this is a 2-year project. We intend also to reach out to the SMAGs, Safe Motherhood Action Groups, providing them with good, correct information on maternity issues so that they are able to support delivery from the health facility, early referral to the hospital. So in conclusion, ZAGO believes with your support, we can reach this target of 70 maternal deaths per 100 by 2030. We appeal to you, you have been with us all along as partners with good political will from MOH. We believe we have the expertise, we are found all over the country, and we feel we can contribute together to a historical achievement of having fewer maternal deaths or completely marching towards zero as we reach 2030. Thank you so much.